Everybody. Welcome to our third IBD Gecko meeting, and it is the last one for 2020. So far, we have 49 registrations for this meeting, delegates from 10 different countries: Nigeria, Botswana, Cameroon, Zimbabwe, Tanzania, Mozambique, Zambia, Sudan, Kenya, and South Africa. So the theme of this afternoon's IBD Gecko is acute severe ulcerative colitis, which is arguably the most dangerous condition that we see in the field of inflammatory bowel disease. So I'm going to start with two short presentations from UEGW. So they're hot off the press, just a month old. And then we're going to have a case presentation by Dr. D Claassen. So the chat will be open for any questions, which we will take at the end. But of course, if you want to pose questions in person, that's even better. So let's start off with the first case, which is by Dr. Raja Attia from Germany. And this will be followed by Willem Develman from the Netherlands. And these are both really quite impressive IBD experts across the globe. So Karen, if we could just start screen sharing, please.
Karen, you need to unmute.
Start right away. So these are my conflicts of interest. So what are the criteria that really define acute severe ulcerative colitis?
Karen, we can't see your screen.
Sorry, I'm looking for it. I found it.
And one sign of systemic inflammation, like a heightened pulse rate, heightened temperature.
Okay, and I'm going to restart it.
Okay.
Sorry about that.
I'd like to thank the organizers for giving me the opportunity to provide some insights into the medical management of acute severe ulcerative colitis patients in this live crash course. So I've been allocated a time of 10 minutes, which nicely reflects what is also the most important factor in the management of these patients, time. So I'll start right away. So these are my conflicts of interest. So what are the criteria that really define acute severe ulcerative colitis? So we take the modified Truelove and Ritz criteria, so patients with bloody stools of over 6 times a day, and one sign of systemic inflammation, like a heightened pulse rate, heightened temperature, anemia, or heightened CRP levels, do really fulfill the criteria of having severe disease, and these patients have to be admitted to the hospital. We can still see that patients with this severe disease have a heightened risk of mortality, especially if there's an indication for an emergency colectomy, as shown in these data that were collected in the United Kingdom. Age is a risk factor for mortality in patients with severe disease, as this in either registry data show patients with an age of over 50 years have a heightened probability of mortality. So of course, this has to be taken into account in the management of older patients. So what happens now if a patient is admitted on day 0 to the hospital with acute severe ulcerative colitis? One should exclude potential infectious complications like Clostridium difficile infection or the colitis. But without waiting for the results of these examinations, IV steroid therapy has to be initiated either with hydrocortisone or methylprednisolone. Again, it's also crucial that therapy with low molecular weight heparin is also initiated, as patients with severe disease have a heightened risk for the onset of thrombosis. The surgeon should also be integrated into the multidisciplinary team who should evaluate if there's an indication for emergency colectomy right away. And of course, these patients then need tight monitoring by this multidisciplinary team. On day 3, response to IV steroid therapy should be assessed. If there is a response, steroid therapy can be continued, oralized, and then tapered. If there's non-response to steroid therapy, again, indication for colectomy should be assessed. If it's decided that the medical therapy can and should be initiated, there are two options. One can either initiate therapy with a calcineurin inhibitor cyclosporin, IV, or infliximab, which have both been tested in randomized controlled trials. So here you can see some indices taken at day 3 that are predictive for corticosteroid failure in patients with severe disease. These consist of heightened bowel movements, elevated CRP levels, and low albumin levels on day 3, which are all indicative for steroid failure in these patients. So, as said before, therapy with cyclosporin IV can be initiated, and this has been proven to be efficacious in randomized controlled trials in a dosing of 2 milligrams per kilogram, which has been shown to be as effective as higher dosing, but associated with less severe side effects. On the other hand, one can also initiate therapy with the anti-TNF antibody infliximab, which has also proven to be efficacious, as shown here after one application of infliximab, leading to a heightened probability of colectomy-free survival compared to placebo. A head-to-head trial, cyclosporin versus infliximab, was also initiated, showing no difference on a short-term level till day 98 regarding colectomy-free survival. If you then take long-term data, as shown here till day 7, of course with low numbers of patients, then similarly there was no difference between patients that were either treated with infliximab or cyclosporin. So there's really equality regarding colectomy-free survival in these data between cyclosporin treatment or infliximab therapy. So on day 6 to 8, again, response to rescue therapy has to be assessed. If patient did respond to infliximab or cyclosporin, maintenance therapy can be initiated. If patient did not respond, of course, again, indication for colectomy should be evaluated for the patient. If patient did not respond to infliximab or cyclosporin, there is the probability that this patient can then be treated with another therapeutic option. But one should and must be aware that switching one patient from infliximab to cyclosporin or cyclosporin to infliximab can be associated with sometimes severe side effects, especially if the patient is switched from infliximab to cyclosporin A due to the long half-life of infliximab. If patient did respond to induction therapy with cyclosporin, there is a need for maintenance therapy, as cyclosporin is only effective on a short-term level, and long-term treatment leads to sometimes severe side effects. So here you can see that patients where cyclosporin therapy was combined with azathioprine did benefit then from azathioprine maintenance therapy compared to therapy with cyclosporin alone. So of course, azathioprine then is an option for these patients, first in a combination therapy with cyclosporin, and then after ending cyclosporin as a maintenance therapy. Same could also be shown for the anti-integrin inhibitor vedolizumab, which again also showed that it can be combined with cyclosporin and then be continued as a monotherapy in patients with acute severe colitis, as you can see here regarding the clinical endpoints response, remission, and steroid-free clinical remission under vedolizumab monotherapy. And here is the first case report coming from our center, where we treated a patient with cyclosporin and ustekinumab, and the patient responded at week 8 with the onset of mucosal healing. And after then discontinuing cyclosporin, the patient was treated with ustekinumab monotherapy, and mucosal healing was still preserved at week 16 and also afterwards. So this might also be a therapeutic option in patients with acute severe ulcerative colitis. So here it could be shown that patients with severe disease have lower levels of infliximab in their blood than patients with less severe disease. And we all know that trough levels are associated with response to infliximab therapy. So why is this the case in patients with severe disease? They lose infliximab over the disturbed epithelial barrier into their feces. And of course, due to this, there are lower trough levels in these patients and also less response to infliximab therapy, as shown here in patients that are non-responsive in red. They have heightened levels of infliximab in their feces, but lower trough levels, and also higher probability then of non-response compared to patients with higher trough levels and lower loss of infliximab into their feces. So might this be the basis for an accelerated induction therapy in these patients? This is indicated by the results of this study, where patients either got standard therapy with infliximab at week 0, 2, and 6, or accelerated treatment where infliximab was applied 3 times in the median period of 24 days. And you can see here where patients that were intensified with infliximab therapy did have a higher probability of being colectomy-free in the short-term interval where this was evaluated. But this could not be confirmed by other studies, and a meta-analysis did show that accelerated infliximab induction therapy did not lead to a benefit regarding different endpoints compared to standard therapy. But if you then look into a subgroup analysis of this meta-analysis, you can see that indeed patients with heightened CRP levels reflecting heightened disease did benefit from intensified infliximab therapy compared to standard dosing, but that patients with lower albumin levels did not. So I think there's an urgent need for prospective trials that really test accelerated versus standard therapy of infliximab in patients with severe disease to really give us a hint what is the best utilized treatment option with infliximab in these patients. Tofacitinib has also been described as a possible treatment option in patients with severe disease. The intensified therapy with 3 times 10 milligrams for over 3 days did lead to a response over in these patients, but of course these results have to be validated and confirmed in further trials. So here you can see the impact of preoperative admission days on postoperative morbidity and mortality following colectomy in these patients. And this again shows you that with a heightened number of preoperative admission days, there's a heightened probability of postoperative morbidity and mortality. Again, reflecting what I said at the beginning, time matters in the optimal management of these patients. I'd then like to come to my conclusions. So acute severe ulcerative colitis is still associated with a heightened mortality rate, and patients must be hospitalized in an experienced center. Do not forget to exclude potential infectious complications. These patients really need tight monitoring by a multidisciplinary team involving gastroenterologists and surgeons. An early introduction of rescue therapies, infliximab, calcineurin inhibitors like cyclosporin or tacrolimus, in steroid refractory patients is crucial for their further outcome. And with this, I'd like to thank you for your attention.
Thank you so much for giving me the floor. And I will touch on, in this talk on the surgical management of severe acute colitis. So here you see my disclosures. So when it comes to patients clinically admitted with severe acute colitis and the surgeon is involved, then it's not about saving the colon anymore, it's about saving the life of the patient. This is an interesting study from the US, which showed results from a nationwide inpatient sample, indicating that there is a shift from emergent colectomy for ulcerative colitis towards elective colectomy. So the rate of emergent colectomy is going down, but if you look at the incidence of pouch surgery, that's stable. So it means that more patients are operated in the elective setting, and this is probably because of a better management with biologicals of patients who are clinically admitted. But it's not all good news, because if you look at data coming from the state New York, and this is also a recent series, then you have to appreciate that the patients who have emergent colectomy still have a mortality rate up to 13%. And if you consider this over time, you see that even this rate is increasing. So after 2007, it's increasing from 10 to 15%. There's a huge mortality variation between the hospitals. So there's a big variance in performance of care, and there are independent risk factors for mortality. So the older the patient, the higher the risk, the longer the patient is preoperatively. So if there's not timely surgery, there's more risk of mortality. And of course, in the recent time frame, there are higher mortalities. So if a surgeon has a high volume, or if it's a colorectal surgeon, or if laparoscopy is applied, then mortality rates are lower. So when a patient comes to the hospital, also the surgeon have to evaluate the workup. So they should be careful history. Is this the first exacerbation, or did the patient already have repetitive exacerbations? And this matters with respect to decision making. We have to exclude infectious colitis. We have to assess the CRP and the hemoglobin and albumin. We have to do a CT to rule out perforation and dilatation of the colon. Of course, the diagnosis has to be confirmed, and the gastroenterologist has the duty to call the surgeon to manage this patient together. So there are two clinical scenarios. The first one is the emergency colectomy that needs to be performed. That's immediate surgery when the patient comes in if they have perforation, or another indication for emergency surgery is the severe bleeding. Most of the patients, they will require subacute surgery within 48 hours if the patient is not responsive to medical therapy because of having a pulmonary colitis, or if they have a toxic megacolon where the colon is dilating. So this is the typically timeline of patients treated medically or surgery. So if the patient comes in, if there's an indication for emergency colectomy, perforation, or bleeding, then it needs to have surgery. If this is not the case, then a true-love schedule can be applied. So patients will have IV steroids, and after for 3 days, and then at 3 days, there's a joint assessment if the patient is improving. Is that not the case, and the patient is still in a good clinical condition, then rescue therapy with biologics can apply. So of course, this takes another at least 5 days before this might work. And then after 5 days, there is a decision making whether we agree that this patient is improving or that it needs surgery. And this all depends on the clinical condition of the patient and also the albumin level. And I'll show you that a little bit later. So the predictive factors for surgery in the long run can be assessed using the preface criteria based on stool frequency and CRP level. And the whole criteria are more or less the same. So at day 3, if they have still a high bowel movement frequency and a high CRP, that there is an 85% chance that this patient requires a colectomy. Albumin is important in this. Of course, if the patient is old, we have less time to try drugs, because we see from data from the UK that older patients have a much higher mortality, particularly if they are operated not timely. And of course, if the patient already had recurrent exacerbations and clinical admissions, then there's another reason to go for surgery earlier. So why is the albumin so important? Because it's associated with failure of medical therapy. It's a reflection of a severe pancolitis, leaking the albumin in the gut. And also it's a predictive factor for septic complications after surgery. So I always say if the albumin is dropping below 2.5, then this patient needs surgery. What are the results on the long term? So if a patient has been treated with steroids, not responding on that, requiring rescue therapy with, for instance, anti-TNF, we have to appreciate that at 4 years' time, 1 to 2/3 of these patients, they will be colectomized. And even after 1 year, this is already half of these patients. We have to appreciate that. So what's the surgical technique we should apply? So it's salvage surgery in this very sick patient. So the patient needs to have a colectomy where we fashion an ileostomy and we close the rectal stump, or we manage it differently, but at least we have to transect the bowel at the level of the proximal rectum. It's very important that we apply laparoscopic surgery because it's associated with less complications, And the shorter stay and on the long run, the body image and cosmetics are preserved. There are less adhesions and incisional hernias, and also fecundity is preserved. So the laparoscopic technique can be subdivided in single port surgery, multi-port surgery, and hand assist surgery. And we can tailor the approach towards the BMI of the patient. So if it's a very lean patient, then we can do single port surgery where we put in the port in the future stoma site. So if the patient wakes up, they only have the stoma and no other incisions. Multi-port for the thicker patients, and the much thicker patients, they can have hand assist surgery. I think open surgery, there's little room for that. Only in the unstable patient, and of course, if the surgeon doesn't have the laparoscopic skills, or as a relative indication, if there's a perforation. Of course, if you don't have a surgeon who can apply a laparoscopic colectomy, find a capable surgeon who can do that, because it's very important for the patient. So what kind of results we can expect after laparoscopic surgery? Well, morbidity is mainly in infectious complications, wound infection 5%, intra-abdominal abscesses 3%. Hospital stay would be typically around 7 days with a full recovery in 2 to 4 weeks. And a second stage, going for a pouch, can be done in 3 to 6 months. So the first stage is the colectomy, and then as a second stage, the pouch can be created after 3 to 6 months. And we have to realize that relatively few patients are counseled and referred to the surgeon for pouch surgery. If we look at data from the UK, only 1 out of 3 patients will have a pouch after subtotal colectomy. And in Sweden, that was even less, because more patients would have ileorectal anastomosis. So it's the responsibility of the gastroenterologist and the referring surgeon to counsel the patient for reconstructive surgery. So in conclusion, ladies and gentlemen, the update on surgical management of severe acute colitis. It's a condition which must be managed multidisciplinary. We have to appreciate that the real-life mortality rates are still significant. We have to apply timely surgery based on the clinical condition of the patient, the age of the patient, the albumin level, and the time and the response of medical therapy. We have to appreciate that there might be less emergency surgery, but the overall rates of surgery for ulcerative colitis are similar because there's a shift from emergent surgery towards elective colectomy. Laparoscopic colectomy and ileostomy is the standard, so find yourself a good laparoscopic surgeon, and proper counseling is key, offering the patient restorative options. I thank you for your attention.
Okay. Sorry, I can't seem to. Okay, thanks very much. Those are 2 excellent presentations. And before we take any questions, we're going to move directly on to our clinical case. This is a case that Dr. D Claassen is going to present for us. He is a fellow in gastroenterology at Tygerberg Hospital and the University of Stellenbosch. And he's going to present a case on acute severe ulcerative colitis in an adolescent. So Dick, if you could start sharing your screen, please.
Good afternoon, everyone. I'd like to thank you for the opportunity to present a case that we saw here at Tygerberg Hospital. I'd like to introduce you to patient J, who is a 16-year-old male with no comorbidities, who is from Ceres, essentially, and presented to Worcester Hospital in August with bloody diarrhea and weight loss of what he...
Dirkie, are you intending to share your slides?
Yes.
There's nothing up at the moment.
Let's just see.
Okay, it's coming.
Good.
There we go.
Awesome. Great. Sorry about that. So I'd like to introduce you to patient J, who's 16 years old, from Ceres, and he was previously well. He presented to Worcester Hospital in August with bloody diarrhea and a weight loss that was quantified of over 30 kgs.
And Dirkie, we're still not seeing your slides unless I'm the only one that's not.
It's showing that it's sharing.
Chris, can you see them?
I'm not seeing it either. No, I'm not seeing them either.
Okay, just stop the share and redo it.
Please say it again.
Yes, that's correct.
Is it showing now? Okay. At that point, he had a HB of 5 and he was transfused with 2 units. He had a colonoscopy done that was documented on the report as severe colitis from the rectum distally, and he was started on prednisone by Worcester Hospital at that point. He stabilized according to them, and he was sent home to follow up his histology at Ceres Hospital. So when he was at Ceres Hospital on the 3rd of September as an outpatient to follow up his histology results, he reported to them that he had been having this recurrent admissions for bloody diarrhea since January of this year. They quantified his weight as 35 kilograms over a period of 6 months. He once again had a drop of HB to 5.2, and they started transfusing him with 4 units of red cells as well. His vitals at that point, his weight was 32 kgs, and he was quite hypertensive with a heart rate of 120, and he had a global tender abdomen on examination. They still continued him on his prednisone, and he was then subsequently referred to us at Tygerberg Hospital. This is just a slide to show you his histology that was done on the colonoscopy at Worcester Hospital, where you will see the distortion of the crypt architecture and the expansion with basal plasmacytes as the inflammatory cells that shows us evidence of chronicity of the disease. So when he arrived at Tygerberg on the 4th, he had a stool count of 16 bloody diarrheas a day. He had a heart rate of 120. He had an elevated white cell count of 21. And even after receiving 4 units of blood, his HB was still 6.8. And his CRP was 170. And as per previous presentations, we know that according to True Love and Bits criteria, he's got severe ulcerative colitis. I'd just also like to point out that his stool MCNS at this point was normal. He was negative for C. diff, and there was no evidence of CMV as well. And his blood cultures also didn't show any growth. His x-rays here at Tygerberg, you can see that there is loss of Haustra on the colon on the x-rays as well. There's no evidence of perforation at this stage, and there's also not real evidence of a toxic megacolon. His CT was quite interesting. He had inflammation of his rectum, his sigmoid, his distal ascending colon, with also mucosal thickening and hyperenhancement. He had engorgement of his pericolonic vessels, and there was loss of Haustra as well. They were also concerned of a possible appendicitis, as the appendix was dilated and there was also air in the lumen. Another interesting finding is that he had bilateral iliac vein thrombosis, but there was no evidence of perforation or toxic megacolon on the CT itself. We repeated a sigmoidoscopy for him here at Tygerberg, which showed a Mayo 3 classification with spontaneous bleeding, continuous ulceration, and we repeated the biopsies once again. My question goes out to all our listeners to what would you do next? Would you consider giving him infliximab, changing his steroids to IV steroids, giving him cyclosporin, or to consider surgery at this point? If everyone could just answer on the poll that Karen or Cheryl will show for us. Okay, can we share the poll, please? Okay, so 41% of you would have initiated an infliximab at this point, followed by IVI steroids, and we'll see how that fits in with our decision here. So on his histology further with us, they showed a lot of neutrophils in the cryptoepithelium, which is indicated by the white arrows on the picture, which shows us that there is definitely disease activity at this point. So what did we do? Because of his iliac vein thrombosis bilaterally, we increased his Claassen at this point to 40 milligrams subcut BE. We continued him on his antibiotics that he was started on at Ceres Hospital. We stopped his oral prednisone and we made it IVI hydrocortisone, which we gave at 100 milligrams QID. And we also started him on calcium and vitamin D. On day 3 of review on the MDT meeting, we did a round with our colorectal team and our gastroenterology team, and he seemed to have improved quite drastically. His heart rate came down to 90, and he had to still count more than half to about 6, not all of them bloody diarrhea at this point. And his CRP also decreased to about 90. The only concern at this point was still a white cell count of 21, and after multiple transfusions, his HB was now 7.6. On subsequent evaluation at around day 6, his HB had stabilized about 8, his white cell count had come down to 19, his CRP was 12, and he had a stool count of 4, but no bloody diarrhea at this point. So come Friday morning, before Friday morning and around day 7, we changed him to oral prednisone of 60 milligrams a day. We also started him on sulfasalazine 1 gram PD, and then to find him Friday morning on our MDT meeting to have a peritonitic abdomen and once again raised inflammatory markers. His heart rate shot up to 110, his temperature was 37.8, and his HB dropped from 8 to 5.2 with another raise in his CRP to up to 88. So what next? So if you would choose once again, A being IVI steroids, B infliximab, C cyclosporin, or D surgery. If we could get the poll up again, please. And the results of the poll, please. 75% surgery and 25% infliximab. So here's what we decided. Surgery. So he was quite ill with a peritonitic abdomen, and with his clinical presentation, him deteriorating so quickly, and it being a Friday, we decided to opt for surgery. Our colorectal team did a laparoscopic total colectomy, as illustrated in the talk just prior to mine, with a Hartmann's and ileostomy as well. And his colon was sent to histology, and as you can see, not a very happy colon there. So just to illustrate the indications for emergency surgery is when a patient with UC has massive life-threatening hemorrhage, there's a toxic if there's a colonic perforation, or if there's a total obstruction from a stricture. So the colon was also sent for histology, and I'd like to show you some of those pictures. Here you can see inflammatory pseudopolyp with an island of large bowel mucosa surrounded by ulceration. You also see collection of neutrophils in the laminar crypts, which is features of disease activity. Just more illustration of the basal plasmacytes as we showed before. So post-operatively, unfortunately, he had quite a prolonged stay with us after his surgery. He developed wound dehiscence with hematoma. We had to stop his anticoagulation as there was concern that the anticoagulation played a role. He developed temperature spikes. There was a concern of a possible rectal blowout. Sepsis, his blood culture subsequently showed a Klebsiella pneumonia, and he was started on ertapenem. The CT at this point was also done, which excluded a rectal blowout, and he settled on his antibiotics and IV fluid management subsequently in the ward. He then stabilized, his wound healed, his stoma was working perfectly. Our dietitians were involved with him as well to up his feeds and his albumin. He was started on warfarin 5 milligrams daily. We also started him on budesonide enemas, and he was discharged eventually on the 7th of October, quite healthy and much better looking. Thank you very much.
Great, thanks, Dirkie. That was a great presentation. So I'm not sure if there's any questions for Dirkie, myself, Chris. Chris, any come up on the chat?
Yeah, there are a couple. Dirkie, thank you very much for that presentation. Jill, before we take questions, just a couple of issues. I'd like to thank the UEG very much for allowing us access to these talks, and we will be making access, we'll be making these talks available. These two talks were actually taken from the UEGW virtual week, which was just given a few weeks ago. The other aspect I wanted to just quickly say, Joel, was that we will be introducing IBD pathology to these sessions in next year. Those of you that were on our Gecko last week will have been surprised to see pathology as part of our teaching. So we've started with hepatic histopathology last week, but we will be extending to IBD pathology. But I'd really like to thank you, Dirkie, for an excellent case. So, Jill, there's a question on the chat about using abdominal CT scan following X-ray evaluation in severe acute ulcerative colitis. What are the indications, and should you be doing this?
Okay, so you definitely don't need to do it on all patients. You need to assess the clinical situation. So really where I think a CT scan is indicated is if there's significant pain, because ulcerative colitis is not a disease of pain. If a patient is having significant pain, you need to get very, very concerned that there might be a pending perforation or possibly a small one that you missed on the chest X-ray. So that would certainly be the type of person that I would want a CT scan. The other one is if somebody had a really, really high CRP that was a little bit out of keeping, but certainly not on everybody.
Right, and thrombotic episodes, the patient had bilateral thrombotic, it was DVTs, I think, Dirkie.
Iliac vein thrombosis.
Yeah, sorry, iliac vein thrombosis. So, Jill, will you comment on thrombotic?
Yeah, so IBD, active IBD is a highly thrombophilic disorder. So, which is why if you ever admit somebody...
complications in IBD,
yeah.
Very well described.
Yeah, so if you admit anybody with acute severe ulcerative colitis, they really do need heparin prophylaxis from the very beginning. So, you know, this patient had significant inflammation probably for some time. And so it's not at all surprising that he did clot up his iliacs. You know, we've had one patient where they actually had extensive small bowel thrombus and actually landed up having almost catastrophic surgery in somebody who had uncontrolled ulcerative colitis, and she delayed coming to hospital for several weeks. So we nearly lost her, but luckily it was caught in time.
All right, a very important complication to be aware of. And Dirkie, a question on the rationale for your choice of antibiotics, the cephalosporin and ampicillin.
So these were antibiotics that were actually started at Sierra's Hospital. And the patient was then continued on this. We didn't want to stop the antibiotics. I think the main concern initially was the raised white cell count. Although I don't think they really thought about the longevity or the long course of steroids that the patient was on. Also, the CRP was quite elevated in him having his tender abdomen. I think they just wanted to cover bases for sepsis that could be lurking as well.
And Jill, comment on your
Can't hear you, Chris.
Choice of initial empiric antibiotics without culture, and your choice of antibiotics empirically in a newly onset or in a presentation without culture positivity.
Okay, well, all of the guidelines recommend against giving antibiotics.
What would be your
ulcerative colitis.
empiric choice of antibiotics?
Okay, well, antibiotics, all the guidelines suggest that they should not be given for acute severe ulcerative colitis. Having said that, everybody gives them. This is because it is such a dangerous condition, and certainly, I mean, this is very much my personal practice. It's not evidence-based at all, but that colon is just so sick. And you know, these patients, I'm sure they're just translocating all the time. So certainly I think it makes us sleep a little better at night, knowing that there's some antibiotic cover until we can be certain that there is no actual sepsis going on here. My choice of antibiotics, if I did choose, I like a cephalosporin and metronidazole. This is particularly if it's your first time presentation and you haven't quite ruled out an infectious colitis or C. diff.
Okay, and if your patient has been on steroids for a few days, your kind of approach, does it differ? And also, just to emphasize the need to exclude CMV aggressively in these patients.
Yeah, absolutely. So patients that present with acute severe ulcerative colitis, they all need to have a flexible sigmoidoscopy. A full colonoscopy is frankly dangerous, but the flexible sigmoidoscopy with biopsies, and you need to ask specifically for CMV, because CMV absolutely loves a sick colon. And if you've got acute severe ulcerative colitis with a concurrent CMV infection, the chances of you getting on top of it with intravenous steroids is much lower. So you need to treat them with both intravenous steroids and intravenous ganciclovir. So it should be done routinely on that admission for acute severe ulcerative colitis. And your other question, Chris, a patient who'd been on prolonged steroids.
So are there any other questions?
So I think we just all, I think what
Sorry, Jill, carry on.
Yeah, I think what this case illustrates very nicely is that once patients have been on steroids for a long period of time, or a fairly prolonged period of time, they have essentially failed them. And you need to move on to escalated therapy, because doing surgery, our surgeons are obviously, they're very concerned about operating on steroid saturated patients, because that's when they literally do fall to pieces. So I think the key about acute severe ulcerative colitis is be very proactive. Get in there quickly. If your steroids don't work, rescue them quickly and then send them to the surgeons quickly. You mustn't spend prolonged periods of time delaying. I think in that presentation from Willem Bellerman, he showed you quite clearly how post-operative complications and post-operative mortality increase significantly if you go past 7 to 10 days of medical therapy.
Feel free to ask a question. Jill, I was impressed how a simple measurement of albumin has such predictive.
Yeah, it's one of the major predictors at the time of initial presentation that will predict whether you go on to get a colectomy. Yeah, and the reason that it's so predictive is, first of all, because I mean, obviously you've got a huge inflammatory burden, you're just leaking into the gut, and also because of the incredible inflammatory response. So it's an excellent marker of disease severity. So on a presentation, if you've got a patient who's got an albumin particularly below 25, you know that this patient is in serious trouble. And the issue.
Okay, any other questions? I see. Sorry, Jill.
So just another issue that I don't know if everybody picked up on. The sound was very, very soft. But in Dr. Trier's presentation, he mentioned accelerated infliximab dosing. So this is sort of the flavor of the month. It has not been proven in an evidence-based fashion, but the rationale behind it makes perfect sense, is that you want infliximab levels to be high because they need to be therapeutic. And the problem is, if you've got a really sick colon, they just pour the infliximab into the stool. So there's this concept of accelerated dosing where you give 3 doses over a 3-week period, or otherwise you start at a higher dose, like 10 milligrams per kilogram as your first dose. As I said, it's not proven, but it makes intuitive sense. So in my opinion, I can't do it at Prinscure, obviously, because of the costs involved. But if you can access infliximab and you can access 10 milligrams per kilogram, certainly I think that would be the best way to initiate therapy. You've got a very short window of opportunity to save that colon, and you know, you got to go in there all guns blazing.
Thanks very much.
Shiraz, I see you.
Paul, I see there's a surgeon with us, Paul Goldberg. Paul, have you could you unmute, and do you have any comments or points to make?
I don't actually. I think it's all been said. I was one of the people that said right at the beginning, this is going to go bad. Do the surgery and stop messing around. I wasn't really in the. I was in the minority, but you know, this case was clearly going to come the surgical way. And clearly we don't like lots of steroids for a prolonged period of time, though, you know, sometimes we have to work with them. I don't really have any other comments, unless there's something specific somebody would like to ask me.
I'd like to make a few comments on this case.
Thanks, Paul. That's good. Shiraz?
So the situation is always very difficult. The patient who comes in semi-hot to you, who had steroids before, something happened before, was treated as an inpatient, treated as an outpatient, they are very, very difficult. And in my mind, it's quite difficult to decide, do you follow the algorithm, 3 days of steroids and make a decision, or do you modify, do you give them more time, but then you give them more steroids? It becomes quite difficult to pin the patient down exactly where you're going. But do you operate on somebody, like a 16-year-old upfront as he comes through the door, which is quite a difficult decision to make. So that's my one comment. The second comment is, we normally use hydrocortisone, but to get actually 4 doses of hydrocortisone into a patient in our hospital in a 24-hour period can be sometimes quite difficult. Then what do you do in terms of judging? When do you give him 3 days? Do you give him 4 days? Do you give him 5 days? What do you do? I would like to hear from everybody else who deals with this often to see what do they do, or do they use some other steroids?
Joe?
Well, I mean, Shiraz knows we always use intravenous hydrocortisone in our unit. I don't have any experience with any other intravenous steroid. And Shiraz, I absolutely agree with you. It's really difficult making these decisions on these patients, and we all vacillate, and especially such a youngster. And you know, it's very easy through the retrospectoscope, and it's always a very challenging decision at the actual time.
Try and put my hand up, but maybe I should just talk anyway. Youngsters seem to do badly. We misassess them. They certainly with recent onset disease, they are a lot sicker than we think they are, particularly when they've been on quite big dose steroids before we even get to them. And our emotion is to save the colon. But in fact, by delaying this patient, waiting for the peritonitis, the mortality goes from 0.4% to 40%. Well, maybe not so high in a young person, but in a very young person, but clearly we're really risking this guy's life in order to save his colon.
So the other thing with him is that we will. Sorry, Chris?
Sorry, Shiraz, carry on.
So the other thing with this specific patient was that he required at least 2 transfusions before coming to us, which made me very concerned about him, because normally UCs, you don't need him to transfuse him acutely. So he had 2 transfusions outside before coming to us already. And then he suddenly dropped his HB on the Friday morning. And we had a quick MDT. Myself, Tim, and Khalid got together. We had a discussion, and we decided to operate on him. And within an hour, he was in theater. And Tim said that was the sickest colon he's seen without a perforation. So I think we made the right decision. It was not an easy decision to make, but we made it as a group.
Paul, since we've got you here, your thoughts about ileal anal pouches. Is it ever feasible to do them in 2 stages? And what is your feeling about ileorectal anastomoses in going down the line?
Okay, before we get to that, I'd like to just highlight in this guy with his bilateral iliac thromboses, to manage his DVT, his venous problems, requires anticoagulation. And anticoagulation with a colon like this is going to promote massive blood loss. So, I mean, you really are between the devil and the deep blue sea. You can't manage the anticoagulation until you get the colon out, not effectively anyway, without requiring significant transfusions. So that was one of the reasons that I felt that surgery was indicated. 2-stage, 3-stage, ileorectals are easy. What you do to do anyway. But what you end up with is you start off with a sick patient with diarrhea and incontinence, and you end up with a well patient with diarrhea and incontinence. There is a role for them where somebody really wants to avoid a long-term stoma, and you can't get the small bowel down into the pelvis. And you can control the rectum relatively easily pre-op. My thoughts about 2-stage, 3-stage, whatever. Ileoanal pouch is a cosmetic operation. It's about long-term good function. It's about body image and not having a stoma and all the complications of a stoma. However, one doesn't want to sacrifice long-term quality of life to avoid a third operation or a second and third operation in a fit individual. So yes, one can do an ileoanal pouch without an ileostomy, but the best in the world have a 10% leak rate. And if you leak and end up with pelvic sepsis, you can have a poor outcome. So if we can reduce it doesn't reduce the leak rate, but reduce the consequences of that leak. Really, I do enough coloanals and ileoanals to not want to risk that complication. It's about his next 30, 40, 50 years. And chronic pelvic sepsis means he's going to have an endoileostomy. That's my take.
Thanks, Paul. We have a few more minutes. Julian Utley, I see you're on here as well, and another colorectal surgeon. Any comments from you, Julian?
No, is that unmuted now?
No. Yes, excellent. We
you can hear me, yes.
Nice to see you, Julian. Welcome.
Well, as I was listening to the presentation, I thought this is a case of medical fapholitis. He should have had his colon out much earlier. And I agree with Paul. Your first 100 pouches you do with a stoma, and then the second 100 you do without a stoma, and then from then on you do them with the stoma. So why have to go through that learning curve of realizing you shouldn't have tried a stoma-free anastomosis? I agree fully with Paul.
Well, I slightly disagree with you, Julian. It only took me 20 without a stoma.
Oh, no, well, I was talking about the case series that you write up.
Yes.
There is one question for the surgeons.
Oh, Paul, Chris, while you're reading it, can I just talk about the ileorectal?
How do you taper your steroids prior to surgery? Sure.
The argument in favor of an ileorectal, and it's a very old-fashioned operation, was if you had inflammation that was confined to the rectum and a relatively spared, if you had inflammation that was confined to the colon and a relatively spared rectum, then perhaps an ileorectal might be legitimate rather than proctectomy with pouch. And must have done, I think, 2 or 3 of those in my entire career, and all of them, the moment the anastomosis had been done, got a severely inflamed rectum. So you can get very good results with a proctectomy, and I see very little reason to preserve the rectum in this condition.
Julian, except if you can't get the small bowel down into the pelvis. And that happens very occasionally. But like you, we've tried it, failed, in those individuals where I was, with complete mobilization, could not get the small bowel into the pelvis. And I mean, it's kind of 3 out of 400, 500, you know, a couple of hundred of these things.
And thanks very much. There is another question, a final question on tapering steroids prior to surgery. So in general, give us your comments in general, and then in this situation where you have an acute colitis on board.
Repeat that question, Chris.
It's the tapering of steroids prior to surgery. The concern from Dr. Kandala is that you know, it promotes sepsis, etc. So give us your approach or your feelings about prior steroids usage and complications after surgery.
Look, steroids increase complications. Reducing them means that your disease increases. So you, in the chronic rather than the acute. So you've got to balance the risk of steroids versus the risk of the patient becoming more ill. In that case, I get the colon out on steroids and then do the reconstruction at a later stage, clearly when the patient is well. The only indication I have for an emergency colectomy, including a pouch reconstruction, is a patient who's bleeding massively and you don't know where the bleeding is coming from.
Right, thank you very much. I think that pretty much winds up everything. I was going to ask our pediatric surgeon, Penny Rose, for final comments. I mean, we can't end off on a surgical note, but I see she's no longer with us. All right, well, then that remains for me to thank Dirkie very much for this excellent case, to Jill for chairing, and to the surgeons, Paul and Julian, for excellent comments. So we will resume again in the new year, and really we look forward to these IBD sessions very much. I'm going to ask all our participants for your indulgence today. I just wonder if you could all start your video or show your faces on your screen. We'd really like to take a picture to capture everyone online, because we're going to use this for a case presentation. And I just wondered if you could just show your faces, and I think Karen's ready with her cameras. But thank you very much again to everybody for all their contributions to this wonderful
Chris,
meeting.
we'll only do it if you send us a model release form.
A bottle of what?
A model release form, so that you can use our images.
Okay, well, I have your permission, I'm sure. You're so handsome, Paul. What can we say? That's coming on very nicely. Keep going, keep going, keep going. Julian, where's your face? Thank you, Wayne. It's nice to see everyone. Karen, are you okay?
Yeah, I'm going back to the first screen, getting a few more pictures there again. Most people are on, thank you.
This is great, thank you. Just a minute or two.
A few more here, please, if we can. Wanda, are you there?
Yao.
Yeah, Sabella.
I'm trying to get through. Let me get my camera on. Doesn't want to.
Yeah, I can't find a button to press to make my camera turn on.
Right in the left corner.
Next to the microphone button.
That's great. Thanks, everyone. Very
Okay,
nice.
well, thank you very much. Bye-bye, everybody.
Cheers, all.
Thank you.
Bye-bye. Thank you.